So, I'm just curious if any of you have had any experience with patients who've had COVID-related voice changes.
Not voice changes, but I work a lot with COVID patients, and it's not voice that's really the problem. It's using the voice that's really more problematic than anything else. That's tiring out, coughing, tension, feeling tight in the chest during speaking, not having enough power. That's really the issue. Not having word finding, like all of the other neurocognitive stuff is a
Right,
problem too.
right. So not any voice specific other than just fatigue and secondary to coughing and ventilation and all of that. Yeah.
Mhm.
Um, the
I've I don't have patience because I'm in graduate school still, but my father has from last fall, last November, has changes in his voice, and yeah, it's weaker for sure, and hoarseness and tremoring.
oh, interesting. Okay. Well, what we're going to talk about today is something that we're seeing. Hi, Blair. Something that we're seeing more with the Omicron variant than the Delta. But um, I've had several patients with problems secondary to nerve issues in the larynx, and that's what we're going to talk about tonight. Um, and it's applicable to other viral neuropathies that happen from any kind of virus, but um, the laryngologist that I work with a lot, Dr. Opperman, um, said that this is his he's hearing it's being called COVID voice. I don't know if that's actually the case, but I thought it was an interesting topic because I originally was going to do superior laryngeal nerve paresis a long time ago, and this ties into that too. So it's just a little bit of that. So why don't I go ahead and start? Let's see. I paused my share and now I don't know how to take it off of share. Let's see. Just stop share. Ah, there is everybody. All right, let me give this a go again here. Okay, so can everyone hear me okay? Perfect. All right. Um, so this is just not necessarily specific to COVID-19, but this is something that we're seeing with COVID-19. So I was just kind of having fun here with just reminding us of all of the aspects of normal phonation, um, because the problem that we're seeing in the COVID voice is that there's a weakness in the vocal folds, either from the recurrent laryngeal nerve point of view or the superior laryngeal nerve point of view. And obviously, COVID is a vascular disease. It really impacts the lungs. Um, and so, if you have a patient who doesn't have normal breathing capacity, obviously, voice is going to be affected. Um, and so if you also can't generate enough pressure from the lungs to initiate voicing, that's a problem. But when you combine that with a weakness in the larynx, then it's especially difficult. So you have weakness and fatigue and compensatory muscle tension, and all the things that we treat on a regular basis as voice clinicians. Um, I like this little GIF because it's just kind of a fun thing to think about. The need of the vocal folds to close well, pressure generation, and then the vocal folds vibrating by closing from the lower lip to the upper lip, and then the vibration of vocal fold is propagated. And also just a review of the normal cycle to cycle variation of vocal fold closure pattern, which again, I'm reminding us of this because that's always our goal when we're working with these patients, is to really try to reestablish normalcy in vibration. And obviously, voice is not the most important aspect of the function of the larynx. So if these patients are compromised with their breathing, that's a huge deal. And on ventilation for months at a time can end up being vocal fold scarring, tracheal scarring, difficulty long-term with breathing and voice production. And often too, that we're starting to see some nerve damage, so that there's vocal fold paresis or paralysis. So now we have an airway protection issue, an airway clearing issue, and a phonation issue. And so not only are you managing breathing with your patients, but you're managing swallowing disorders, some dysphagia on liquids primarily, but sometimes all substances, and then obviously voice. So I'm showing this little cricothyroid muscle because when there's, especially with Omicron, it seems like the cricothyroid muscle tends to be affected a lot with the viral manifestation in the superior laryngeal nerve. And so without this functioning muscle, we lose the ability to stretch the vocal folds normally. Pitch is obviously a major factor. So people who use their voice professionally, singers especially, are really compromised by even a small paresis of the cricothyroid muscle. So when the cricothyroid contracts, it rocks the cartilages, so you get this elongation and increased tone in the vocal fold. And when the muscle isn't getting its full synapse information from the superior laryngeal nerve, that can't happen. And it can affect swallowing as well. I've had some patients who've had a paresis and have had some dysphagia on liquids. And I don't know how much, have any of you heard about this? I mean, is it talked about in your voice disorders courses in grad school? No? Okay. And I think that regular ENTs don't really have the subtlety training of when they're looking at their strobes to really pinpoint that kind of paresis. So it is subtle, but it is really important for a singer in particular. I have a rock singer right now who's got a big performance coming up and has had COVID twice and is still suffering with some breathing issues and some voice issues. So and he's in his 30s, so it's really problematic for him. We're having to change the keys of a lot of his songs, getting ready to perform, and he's really stressed about it. He said he's having nightmares about using his voice. So obviously breathing is a huge function of the larynx. But if you have a paresis or paralysis that interferes and the cord ends up midline, you now have some breathing issues. So we, obviously we want to see the vocal folds ability to open well. And also this is also an issue with patients who've been on a vent for a long time because of scarring and limited mobility. And also, I think as we talked about last time, diaphragmatic changes from being on a vent for a prolonged period of time. So this is just a review of a normal exam. Vocal fold tissue is got a little bit of extra mucus here, but otherwise pearly white. Vibration is symmetrical. Most of the time you can see the full course of the vocal folds. Maybe a little bit of AP squeezing, but so that's what we hope to see when we do laryngeal exams. Not always the case, but often. So this was a young female exam. And, just another reminder of the neural control of voicing obviously starts in the brain, the motor cortex. The vagus nerve is the innervator of the larynx, so cranial nerve 10. And the vagus branches into two primary laryngeal nerves, the recurrent laryngeal nerve and the superior laryngeal nerve. So the recurrent laryngeal nerve innervates all of the intrinsic laryngeal muscles responsible for opening and closing of the vocal folds except the cricothyroid muscle. And the superior laryngeal nerve innervates the cricothyroid muscle only. Again, here's just a nice little diagram of the superior branch. This is where the cricothyroid muscle is. And then the recurrent, you can't see on the inside, but it's innervating all of the other intrinsic laryngeal muscles. And the important thing to also remember about the vagus is the course of the vagus nerve goes all the way down around the aorta and back up. So just a good thing to remember when you have a patient who presents with a paresis or a paralysis, that it could mean that it's idiopathic, like we're talking about today, or a viral etiology, but it could be secondary to a tumor anywhere along the course of this nerve. It could be from an injury of trauma, could be from surgery, cardiac surgery, thoracic surgery, thyroid surgery. Those are the most common areas where you would see potentially a paresis or paralysis. So even if you think that there's a clear cut, this is viral in nature, hopefully there's always going to be imaging just to determine that there isn't any other reason for it. I had, back when I worked in Philadelphia, the sweetest priest came in, and he was losing his voice. He was really gearing up for Easter, and it turns out that he ended up having a malignant tumor in his lung that was affecting his laryngeal nerve and the vagus nerve. So he had ended up having to have an injection temporarily so that he could get through Easter. But sometimes we're the ones that end up between our the laryngologists we're working with and our exam. We sometimes end up determining these patients have malignancies, which is kind of sad. But so paralysis or paresis, obviously there's a problem with a nerve that's not functioning or providing impulses to the muscle involved in phonation. If it's an injury from surgery, usually those are more of a permanent situation, especially if it's cut. Sometimes it's just bruised and then it takes some time to recover and there's possibility of recovery. But if it's not moving at all, it's considered paralysis. If it has a little bit of movement, it's considered hypomobile or paretic. And it also could be paretic because of a structural injury, so not necessarily always nerve. But so the things we consider when we have our patients present to us is, what's involved? Is it paralysis, paresis, one-sided or two? What's the position of the vocal fold? If the vocal fold is immobile, where is it located? So if it's more abducted, better airway, worse voice, more adducted, better voice, potentially some difficulty with breathing. And basically, anytime you have a paralysis, you're going to have breathy phonation, running out of air quickly, weakness, fatigue, trouble projecting, decreased range, swallowing difficulties, especially with a paralysis, coughing and choking on liquids and or saliva, maybe even an aspiration issue. And a lot of these things are more important, obviously, than voice. So we have to address those first. Air hunger, stridor, weak cough, all of those things are things that we have to kind of take in as the clinician and prioritize. And I think the case history is so important because a lot of times you'll get a patient who has maybe had an injury, but it took a while for the voice to become weak. And sometimes that happens. You have a virus, you recover from the virus, and then eventually, and then the voice doesn't really fully recover. And that's often the case especially with paresis, but even with paralysis. I have a patient right now who has a true vocal fold paralysis. She had COVID a year ago, and she's a singer, and she just progressively noticed weakness in her voice and more difficulty. But it took, almost a year for her to go in and get scoped because she was compensating so well as a trained singer. And so she was really surprised that she had a paralysis. And we're assuming it's COVID related, but obviously we're not 100% sure. So the COVID voice that is specific to Omicron presents initially with hoarseness, scratchy throat, loss of projection, difficulty with upper range, increased fatigue, and sometimes even complete laryngitis. And I think the singer I was talking about had that complete laryngitis. So the etiology of these problems, the edema and erythema of the cords, the reactive airway and cough issue, and obviously cough exacerbated reflux. But what I'm talking about here specifically is this viral manifestation of the vagus nerve, so recurrent or superior branches, or sometimes both. And so for the recurrent laryngeal nerve, the viral etiology, it can be COVID, it can be just the flu, it can be just a virus, and sometimes you don't even have symptoms of the virus, but it can settle in the nerve and cause issues. It can present as voice and or swallowing symptom with the paralysis, depending on where it ends up becoming immobile. So obviously, the more midline, the better the voice, the better the swallowing, but the worse the breathing, and more abducted, the worse the voice, better the breathing, and worse the swallowing. Normally it's unilateral when it's a viral etiology, but I've heard of bilateral happening. Usually, bilateral is more specific to carcinoma. So we're going to look at a video of a unilateral vocal fold paralysis. When you see, you can, well, I don't have a video of a paresis, unfortunately, but we'll show you the video first.
Okay, now we're going to say E as long as you can. Okay, good. Now give me a low pitch E. Good. And high pitch. Okay, good. Just breathe for me.
So, what did you think of that, with that patient's voice? Pretty decent, huh? But you can see it's pretty close to the midline in its position, and he gets pretty good vibration and pretty good voice from the contact points of the other vocal fold, but it's definitely not moving on the right here.
Will you play it again?
Of course.
Okay, now we're going to say E as long as you can. Okay, good. Now give me a low pitch E. Good. And high pitch.
So what do you think about his stretching ability? Do you think, I just looking at it now, I'm wondering if maybe there is a mixed a mixed scenario where he's got a unilateral vocal fold paralysis, so affecting the recurrent laryngeal nerve, but it seems like he's not really stretching well on this side. Do you guys see that as well? Maybe?
So when he went low to high, it didn't really, there wasn't much movement.
Yeah, you see how he's not really getting much stretch. If you look anterior commissure to posterior, he's got a pretty good straight line as far as his vibratory edge, but when he goes up, and this isn't my patient, this is someone else's strobe, so.
Say E as long as you can. Okay, good. Now give me a low pitch E. Good. And high pitch. Okay, good.
You can see quite a bit of ventricular fold activity there too. See how developed that is there. I don't know, that would be one thing I would just kind of be curious about as his clinician, and see if I could, improve that stretching ability and improve his range a little bit, which would also help a little bit with overall closure. He's got quite a little bowing there going on as well. So the superior laryngeal nerve weakness, it's the viral etiology is the most common, unilateral or bilateral. It impacts singers and professional voice users the most, because those who don't need to have variation in pitch really don't notice that they have a problem often, but they may notice fatigue and difficulty controlling their voice, and sometimes even dysphagia on liquids. But fatigue is usually an issue. Okay, so here's this video. You can see the kind of hula dance vibratory pattern of the vocal folds.
Now just breathe for me. Breathe in and out. Okay, and E. E.
So we really can see the paresis there. Sometimes you'll see, if you're looking at the strobe, you'll see a scissoring so that the weaker vocal fold is a little bit underneath. This gentleman does not have that so much, but the pattern of vibration where it really looks kind of like a hula dance, like the one is following the other, that's really classic vocal fold paresis and specific to the superior laryngeal nerve. He's also got some pretty significant reflux going on, almost like it looks like a little blister right here, and redness around the arytenoids. How many of you are used to looking at strobes? No, so a little bit. So is this helpful or interesting to see these? Yeah. Do you have any questions? I mean, is the orientation make sense? Are you good with the different structures, or yeah, yeah, okay, good. This is one scenario that you would see. The other is, real disparity. Like if these are my vocal folds, you'd see one that's a normal height and one that's significantly shorter, and again sometimes slightly scissoring underneath. But the closure hula is definitely pretty typical for superior laryngeal nerve. So oftentimes I'll describe it as one vocal fold being sluggish. Definitely you can see a reduced length of the affected vocal fold, and even just with normal phonation, not even at a stretched level, but definitely as you go higher in pitch, you see the disparity more clearly. Sometimes if there's so much AP squeezing, there'll actually be a little bowing, and that can be true with a recurrent laryngeal nerve paralysis or paresis. But the scissoring of the vocal folds is pretty classic for paresis for the superior laryngeal nerve. And reduced amplitude of vibration, so how much the vocal folds move laterally, can definitely be impacted, especially at higher pitches. And often you'll see the rotation and tilting of the arytenoids toward the healthy side, which you see a little bit more here. So the vocal complaints with superior laryngeal nerve weakness, I would say most people come in saying, I can't sing my upper range. And I should have put that first, but like, I can't get to my high notes. So that's, especially if they're singers, that's their first complaint. But increased effort and vocal fatigue, definitely. And that's usually because of the compensatory muscle tension that kicks in with any kind of paresis or paralysis. Sometimes even with the superior laryngeal nerve, they'll have difficulty projecting the voice, breathiness and or hoarseness, definitely voice breaks, and loss of range. And I would say because of the increase in compression, trying to get the tone in the chord, you'll have more delineated registered transitions for singers. Tightness in the throat, may have dysphagia on liquids. And I say that only because I've experienced that. I had, when I was just a young new clinician, I had a really bad SLNP, and I had every time I took a drink, I would have a little choking on liquids. Um, Luckily, I was working for Saddlehoff, so he gave me steroids, and I figured out how to rehab myself. And it was a lot of stretching exercises, and we'll talk about those later. But it had a happy ending, so that's good. Some of the other differential diagnoses that you hopefully will see, if you have a team that you're working with, that's great. If you're an independent contractor, you'll definitely want to make sure you have a laryngologist and a team that you can refer to. But obviously, anytime there's a neurological deficit, the imaging is so important because it could be a viral etiology, but it could be something else, and we want to make sure that we don't miss any life-threatening issues like any kind of neoplasms. So often the doctor will order a CT scan or an MRI. If it's recurrent laryngeal nerve, definitely you want to look from the skull base to the chest or the mediastinum, sometimes even brain, but some things that we can do, laryngeal EMG, obviously you can do a flexible swallowing evaluation, or if you do fluoroscopy, you can have the patient get a fluoro so you have a better idea of their swallowing abilities. And then objective voice measures, I think, are really important to get a baseline of where they are at the beginning of therapy, so you can actually determine the kind of changes that you're eliciting with therapy. Obviously, video stroboscopy is pretty standard for an assessment, and many speech pathologists are able to do that depending on who you're working with. But so a good stroboscopy, flexible and rigid, would be my preference, but flexible at minimum. EGG shows the open and closed quotient, so you can actually see what the vocal folds are doing. And if there's what I call a big knee in the signal, then that is usually signifying the compensatory muscle tension. Acoustic measurements, questionnaires, vocal health index, those are just getting some good baseline information on your patients is always important to show how much they're improving with therapy. Voice range profile for patients with superior laryngeal nerve paresis, I would say, is really important. Often these are singers, and you want to know kind of where you're starting with as far as their volume and their pitch range. Is everyone familiar with VRP? Maybe? No? Okay. So voice range profile, if you have a K system with the multidimensional voice evaluation tools, VRP is actually one separate program in that whole K system. And basically you have the patient do their loud maximum and minimum loudness, maximum and minimum pitch, and you get kind of like a phonetogram of their voice capability. And then if they're missing 5 notes on their upper range because of the lack of the stretch in the cord, then you can really see the difference after therapy. But it's really specific to kind of singing pitches. So I use this for actors and for singers all the time. I think it's really a really nice comprehensive idea of what the patient's ability vocally is. Obviously, aerodynamic evaluation, physical exam of the head and neck and larynx, and oral mech exam, just to make sure there aren't any other neurological deficits. So the treatment considerations, always optimize vocal hygiene, especially systemic and surface hydration. make the behavioral adjustments if they have reflux. Definitely modify the diet when they eat and drink. Make sure they're taking their medications correctly. That's one of the things that I notice a lot is that patients will just get put on a PPI and they'll take them at night, and the proton pump stops working when you're sleeping. So to take a proton pump inhibitor while you're sleeping is really kind of like throwing it out the car window. It's not really very effective. So making sure if they're on BID proton pump inhibitors, make sure they take it 40 minutes before breakfast, 40 minutes before dinner. And sometimes if it's bad enough, the physicians will recommend like a Gaviscon at bedtime or a Pepcid AC at bedtime. But just understanding how and when those medications need to be taken to be effective is a good thing for the voice clinician, because we're the ones spending the most time with them. And often, it's a rush out the door, here's your prescription, and they don't really get the education on that. So that's key. Also, strategies to improve swallowing or breathing. And I'm not talking about the patients who've been on ventilators for 6 months. I mean, this is geared to the more specific vocal fold paralysis and paresis and superior laryngeal nerve paresis. Can't talk tonight. Always we're looking to optimize efficiency with what the patient has to work with in the moment. If there is a viral etiology, often there won't be anything permanent to consider for at least a year after diagnosis, because we want the nerve to recover. Sometimes the physicians will say even 18 months, but so that means no thyroplasty yet if you have a viral etiology and you have a vocal fold paralysis. Now, I think I'll talk about this a little bit later, but we do consider, like the physicians will consider a gel injection that's a temporary fix, but it'll improve their swallowing and their voice, and those kind of things we help with. Often I'm there assisting in the injection, and I work with the patient immediately after the injection to kind of do some sliding and stretching exercises to evenly distribute the gel through the vocal folds. So that's something that often you will be called on to do if you're working in a voice practice. And so we're going to address the compensations, address MTD, improve the power source for phonation, optimize resonance, consider amplification. If you have a patient who's got a paralysis or a paresis that leaves them really breathy, then, and they're professional voice users, then consider getting one of the head-mounted mic systems with a speaker that's a fanny pack that they can wear so that they have a little more functional voice. We use these in teachers all the time, and they're really helpful at kind of decreasing the overall load of the voice. And then direct treatments, improving closure patterns, improving stretch of the vocal folds, and restoring functional voice. And we'll talk about that.
I have a question, Kate. Which mic and speaker do you recommend?
Well, I think it can be as simple as just getting like a Shure mic with a little mini speaker, or there used to be, I think they still sell them on Amazon, where you can get a fanny pack and that has a battery pack that's rechargeable and a head-mounted mic. The company that I used to work with went out of business, but I think that there's another one, and I'm sure I can find it. I'll find it and I'll send you the link.
Thank you.
Yeah. So obviously, we need balanced airflow, entrainment of the vocal folds to have optimal voice and resonance. So that's always the goal in voice therapy. And how we get there is sometimes creative, especially with a vocal fold paralysis. But you could see, even with the gentleman who had the unilateral vocal fold paralysis with a recurrent laryngeal nerve impacted, he still had pretty decent voice. So there is a lot we can do to help these patients. And I think sometimes the recurrent laryngeal nerve cases are a little bit more straightforward than the superior laryngeal nerve paresis, because you can have a whole range of weakness. And if it's slight, it's obviously much easier to deal with than if you have somebody who is almost, 70% limitation of function of the muscle. I think I had on there, but I didn't say laryngeal EMG is often recommended for patients with these kind of viral neuropathies. I know that it's used a lot, but I'm not sure that I would ever sign up for that, because they put needles in your vocal folds to determine the weakness. And to me, it doesn't really change what I would do clinically. So I'm not sure that I would ask, especially a singer, to go through that. But that's my own personal preference. So as I was saying before, often we will wait for the nerve to heal on its own. But I do feel, and just from my own experience, that the exercises do matter. So telling somebody, okay, your nerve is possibly going to heal on its own, come back, or just let's sit and wait, I don't think is the best idea. I think especially for trying to get some restoration of functional voice, it's really important for us to work with these patients. And I think that the exercise does matter. I think it does improve overall function. So we're going to work on optimizing function in the meantime. And I talked about the medialization with gel and safe swallowing strategies. And that's something you can do the first day you meet the patient, is just tell them how to make sure that they can manage, especially liquids. How many of you have had any swallowing treatment experience? Okay. Have you worked with anyone with vocal fold paralysis? Yeah. No, maybe. Yeah. Blair, what would you recommend for the patient? Or do you remember?
Well, the patient got vocal fold injections, temporary injections to medialize his vocal folds, but we did EMST to increase his cough reflex and strength,
Nice.
just to clear the airway in case anything went down the wrong tube.
Can you explain to everybody what EMST is? So that
Yeah, it's expiratory muscle strength training. So it's this like tube basically, and you can adjust the resistance in the tube, and you put it up to your mouth, and you want to keep your cheeks, you don't want it to puff out when you blow, and it's a nice sharp through the tube, and it just strengthens those muscles for exhalation and clearing of the airway. It helps increase vestibular closure. Yeah.
Very cool. Did you do that at National Jewish?
The VA.
The VA. Okay, very nice. And just some basic swallowing strategies for a patient with a unilateral vocal fold paralysis. Head forward just a little, buying time for the initiation of swallow is helpful. And then as they swallow, they either tip their head away from the affected cords so that the bolus goes down the healthy side, or they turn their head toward the paralyzed side, again, to move the bolus down the functional side. Does that make sense? Yes. Okay. So my favorite exercises for vocal fold paralysis, often the muscle tension is pretty significant because they're really compensating, and with lots of good reason. So direct massage release. I often will, if it's really pretty severe muscle tension, I recommend the use of a little personal massager. It's actually a little vibrator that has an angled tip. So it actually fits really well into the small areas around the larynx. I can send you a link to that too. It's actually called a Lila Lily. I should have brought it up. But it's a really perfect size for working with voice. And inhalation phonation, obviously getting a little better closure and release of the muscle tension. Glottal fry to get a little more relaxation and better contact points for phonation, for a healthier compensatory strategy for voicing. Improving the power source, so working on abdominal breathing and support, and definitely considering amplification so that they don't have to strain. Postural and laryngeal adjustments. A lot of times when you're working really hard to make sound, you start getting your whole body involved. And so really paying attention to the patient's posture and alignment, and also larynx, that can make a huge difference. And then my favorite exercises for superior laryngeal nerve paresis, again, address the compensatory behaviors, but everything with this rehab is about stretch. So lots of slides, low to high and back down, inhalation phonation, because that in and of itself gives the vocal folds a little bit of stretch and better entrainment, and release of compensatory muscle tension. The SOVT in the straw, in lip trill, in lax fox, all of those things, lots of slidey, stretchy vocal function exercises. And then if you have a patient who's a singer and you're not a singer, definitely refer out to a singing voice specialist. I think most of you are singers. So you get to do everything yourself. And then optimize vocal efficiency and vocal hygiene. It's amazing what steam can do for these patients. Just getting an easier vibratory source can really help the entrainment with a superior laryngeal nerve. And there are a lot of singing considerations with this kind of weakness, because their range is majorly impacted, especially if it's a significant weakness. So you need to kind of work with them about their upcoming performances. Maybe like I had to do with my patient, change some of the range of the songs, tune the guitars down a whole step, or just be really creative without having to just not sing some certain songs that he's not able to sing right now. Modifying the length of sets they're singing, really work with compensatory strategies to improve a little stretch and a little closure. I have this this particular patient doing a little inhalation phonation before he sings his phrases, and that seems to really help him. He's also working with a straw phonation every day to get more stretching, and we're optimizing his vocal fold environment. It's sometimes hard when you're working with a rock singer to encourage them to not live in the sex, drugs, and rock and roll. So, really kind of educating them about the impact of partying on voice sometimes is more challenging than one would think. But I think when they're scared enough about their ability to perform, they take things seriously. And then also optimizing amplification. And with professional singers, especially rock singers, or anyone who's non-classical, using amplification, really making sure that they can monitor their voice well so that they don't push. And I will recommend inner ear monitors for anyone who's doing that kind of regular performing. And then this is just because I recognize that the other aspects of voice and COVID really have to do with being on a ventilator, coughing, chronic coughing, the inflammation that that Rachel was describing, a lot of 19% of patients who get COVID are hospitalized, 5% end up on vents. And they also can end up with, serious hoarseness, difficulty swallowing, vocal fold scarring, and airway scarring. It's just I feel so much for those patients because it's just a long, long road ahead of recovery. And a little Ted Lasso for you. So I know this was a lot of like information. Are there any questions about anything that we talked about today, or anything else related to COVID or voice or patients you might have experienced?
Yeah, I'm curious. I I do work with a ton of COVID patients, and every time I've sent them for laryngoscopy, they're fine. In fact, almost all of their medical tests are coming back fine, but they're not feeling well. They have dysautonomia, racing heart rate, chronic fatigue, crashes, all of this. And that leads to now I can't, like I've got flight attendants who can't work because they can't talk with power. So there's nothing in terms of like a pathology going on with them that's been diagnosed. Now, maybe that's the problem, that it's just a poor diagnosis. But so we're really dealing with more like dysarthria. Um, what do you see when somebody does have a positive pathology? Is it really like are you seeing a lot of paralysis paresis with this patient population? I mean, I think it really varies with the ENT that you see.
Right. Well, and that's why I was saying an ENT who's hasn't done a laryngology fellowship doesn't have the training to pick up these subtleties. And I think a superior laryngeal nerve paresis can result in all of the things you've just described, not the dysarthria, but but the hoarseness, the difficulty projecting, the fatigue, all of those things are subtle changes. And I mean, the case that I showed you was not subtle. You got this, but oftentimes it will be just a height disparity or a little scissoring, and it is significant to certain populations. I mean, some people can have a paresis and not know it and go on with their life and not feel affected. But some people are so sensitive to even just a little bit of biomechanical shift in the way their vocal folds vibrate and close, and they find it's an irritant. It's creating a vibratory change, and so that they're having hoarseness or breathiness. Yeah, it's significant, and that's why I'm talking about it, because um, it's unfortunate that even some um, really good ENTs just don't look for that subtlety. They're looking for the big nodule or polyp or cyst um, or reflux or something. They have maybe a little clinical bias on what they're looking for, and so they see relatively normal looking vocal folds and they say there's no problem. Um,
Yeah, and then I've got people who are 22 months past their first diagnosis, and
wow.
they're still not well, and they're just looking for answers. And I would like to believe that it could be something to do with the vagus nerve.
Yeah.
But I mean, first of all, I would never have that power to say this is definitely that. But I would like to be able to suggest something, anything that's not just, gosh, I don't know, let's try this, let's try, just keep
Right.
throwing things out there.
Well, so, I mean, part of the reason I started the presentation with normal function is just to kind of refresh our approaches to what could be wrong, what's supposed to be happening, and what maybe isn't happening. And even if you don't have the diagnosis, because we're not technically doing that, you have the patient in front of you. You have the experience of their ability or inability to do something. And so that's how you approach the treatment plan. You think, okay, well, this is what I'm seeing and hearing. This is what they're telling me. The patients know themselves better than anybody. And if they're saying this is my experience, then we meet them there, and we do whatever it means we need to do to get them to feeling better, sounding better, experiencing voicing with more efficiency and comfort. Yeah, I know it is really frustrating sometimes because you know that there's something wrong, but there isn't necessarily a definite answer. So I always just default to what am I experiencing with this patient and how can I make that better for them. And I think sometimes just addressing the compensatory muscle tension is is a big one, because obviously if they're experiencing something that's not feeling right to them, they're obviously doing something to kind of brace or modify how they're phonating. So, um, do you have any go-tos that you like for your patient? Like if you have somebody like this, what would your strategy be?
Well, so I work in groups with people because there are
Nice.
just too many for me to to see individually. So we do a ton of massage. We do all of the massage techniques.
Right.
I've started using inhalation phonation.
Right.
And then we just do, because I can only see them for a short amount of time because the looking at the screen is too hard, following, like they get very tired. And I have people who say that 45 minutes that they work with me is the most tiring thing that they do all week. And I'm going, gosh, we're just doing basic breathing. I can't make it easier. I
Right.
can't substep this. You know,
So this is all on Zoom or
yeah, it's on Zoom.
proxy?
I have people from all over Canada who have been through with the respiratory physiotherapist that I work with. So I'm not the only one on the team, but yeah, so I do a lot of inhalation phonation. Then we work basic syllable level, word level, like I move through the hierarchy, and always end with, then we have to bring it back to quiet breathing, just simple breathing, because the heart rate goes up, and for some people their resting heart rate is like 120 beats per minute.
What?
Yeah, I mean, I think I tend to see people who are on the far end of the curve because they get referred into the respiratory physio clinic.
Okay.
But,
Wow.
so we have to really be careful about the sympathetic parasympathetic triggers.
Right.
So we have to keep it really small. And that's a problem because I've got people who, like I said, like the flight attendants, I've got soccer coaches, and when they need to use the power, that sets them off.
Hmm.
And so, I can amplify them, and that's like a stopgap measure.
Right.
But like they're just not getting any vocal diagnosis. And so that's frustrating because I wonder, if there is a paresis or something going on that could be addressed from a medical standpoint. I would love that, but
Yeah.
it also takes over a year to get into the ENT here. So
What?
for laryngoscopy, yeah, Canadian medicine,
Where
it's
are
free, but
you?
it takes
Where
a
are
long
you in
time.
Canada? I can't remember.
Yeah, yeah.
Are you in BC?
No, I work out of Alberta, but I'm in Ontario now.
Okay.
Yeah,
That's crazy.
yeah.
Are there any laryngologists in Canada that are in that area, or are they all ENTs or?
Almost everybody is a general ENT.
Okay.
And there is in Calgary where my clinic is. There is a voice clinic, but I think that they're head and neck who have
Okay.
moved into laryngology. So
Okay. Um, I apologize that I'm looking up. I've got a big monitor. Um, so I'm trying to get it back on my laptop, but here we go. Here you are. Okay. Um, so Does anyone else have experience working with patients with paralysis or paresis? Yeah.
Sorry, go on.
Okay.
I was gonna say, I like my main experiences have mostly just been the only time, especially in the acute care setting, that anybody cares about a paralysis or paresis, which is primarily paralysis, is when it's causing a patient to silently aspirate. And it's like the one main barrier, or aspirate and they can't eject it. So in that setting, you really can't, they really don't like to intervene in the acute care setting unless that it that is like the deciding line between a patient being on a diet or not.
Really? Okay.
Yeah. Otherwise, like if it's voice, they're like, oh yeah, wait it out. We'll get you to, they have a laryngologist on staff now that they refer to as outpatient, but like you can be completely aphonic. They don't care as long as you're eating. They're going to leave it.
Wow. That's unfortunate because when patients can't communicate, it really changes their whole outlook on life.
Yeah.
They get depressed, they change. I mean, they just, yeah, that's really, really sad.
And I think part of the situation where I work as well is that most of the ENTs who are coming onto the floor to see these patients are residents. And we have a teaching program in our hospital. So it's a lot of medical residents who maybe aren't necessarily the people you want doing your injections. They can be hard to get a hold of the ENT, like the attendings. So
Right. Yeah. You don't want someone practicing on you.
no.
Anne, did you have a question or a patient experience to share?
Oh, there we go. It was a while ago. I was doing my CFY and a sniff, and I had one patient in particular who was younger. He was ex-Navy, and I think he was like late 50s, maybe 60 tops, who had he had had a stroke before, and then he had had another one and ended up with voice and swallowing issues. So it took forever to advocate to, just to get him seen by somebody. And thank goodness he finally was able to get seen, and they did an injection, which helped a lot. But until then, it was just really, managing swallowing, just, small bites and sips, head turn to the the weak side, and just I didn't want to work too much on voice till I knew exactly what was going on. So we
Right.
just had to kind of wait it out. But, I gave him some minor things to kind of to do. But yeah, I remember that being so frustrating because it was so difficult to get anybody seen or scoped in the sniff. And it was just like pulling teeth, and you had to I can't treat them. What, just treat them? No, I can't until I know what is going on.
Right.
So.
Yeah, and actually, sometimes doing voice therapy can improve the swallowing function. So it's something that's overlooked a lot when you're just looking at it very isolated. Like this is their swallowing, this is their breathing, this is their voice. Well, it's all the same mechanism, and if we strengthen it for one, we strengthen it for the other. So just continue to advocate for your patients. That really, really important. Um, the other thing that I wanted to share is this client of mine who's a patient of mine who's a singer is actually really functional with the vocal fold paralysis. And so that is really encouraging to me. I think that there was another patient that I had who was a rabbi who had a vocal fold paralysis, and it never resolved, and he never had a thyroplasty or anything. He just kept using his voice and using the strengthening exercises from therapy. And I think sang as a cantor for 20 years or something crazy like that. So So it doesn't necessarily mean they're not going to be able to sing anymore. And I think that's really important to share if you have patients who are singers who have a unilateral vocal fold paralysis or even the superior laryngeal nerve paresis, that it doesn't mean that they're not going to be able to sing. That it, sometimes it takes 6 to 12 weeks to get their function back. But if they have one healthy cord, then usually you can train them to have healthy compensation so they can improve their function and improve their range, especially with superior laryngeal nerve being weaker. But if you are working with a physician, if somebody has a sudden voice change linked to a virus, actually steroids early on can be helpful to decrease the inflammation of the nerve. And unfortunately, we don't always get that luxury of being able to see somebody right after the virus or the change in the voice. Usually it takes a while for them to figure out that there is a problem. And that's with any kind of paralysis or paresis. Unless it's an iatrogenic, like surgical cut, no voice kind of thing, then it's pretty straightforward. And then usually they do something right away, like a thyroplasty. Because I don't know if nerve anastomosis for laryngeal nerves has improved at all since the 80s, but or 90s. Does anyone have any experience with that at all? Okay.
I had a friend who had a thyroidectomy and then ended up with paresis and very breathy, so AB duct. And I said, you can get voice therapy, and the doctor refused to refer her and said, no, it'll resolve. And luckily it did, but it was months before it did resolve.
Wow. I don't understand that mentality at all.
Right.
Because if someone's having an issue, if you give them a tool to address and manage that issue, they end up having less negative compensatory interference in good voicing afterwards.
Mm-hmm.
Yeah, I had a case similar when I was working solely as a voice teacher, and I had a student who had had open heart surgery and had sudden loss of range. And again, it took 6 months to get in to see the ENT. But when we finally got there, sure enough, there was paralysis paresis. I can't remember exactly what it was, but I went to the appointment with her, and the speech pathologist was there as well. And the doctor said, let's wait this one out. And I specifically requested a course of voice therapy to the speech pathologist, and she said, there's nothing we can do. Keep working with your voice teacher. And I'm going, but I don't think that's right.
No, right. That's why we're having this conversation tonight.
Do you have
Because
any like great research that if we're ever in a position like that with a physician that we can bring and say, here's some really great evidence that shows that the earlier we get in, the more positive the outcomes will be?
yeah, I'm sure there are articles I can put in the Google Drive for you just to say, hey, and blah, blah, blah. Yeah. I think that's always a good idea. That's why when I come across them, I'll just throw them in the Google Drive. Have you all had an opportunity to look at what's on there? Yeah, I threw quite a few things in there, things that we haven't necessarily talked about, but if you are bored on a Saturday, you can kind of go through and look at the different things. I do apologize. I was going to share the recording from the pregnancy and the voice from last month, and I felt awkward sharing something that people paid tuition for, so I'm going to just do my own specific presentation for you, and I'll stick it on the drive, because I just thought that's probably not cool. Um, but uh, is there anything that you would like to know about hormones and the voice that I can add to it since I'm starting from scratch?
I think for me, and you may have an idea of a separate presentation that you'd like to give on gender reaffirming therapy or gender affirming therapy, especially in regards to the people who obviously there's hormonal treatment on both sides. One is more beneficial than the other. But that's something that in regards to hormones, I would like to talk more about as well.
Sure, absolutely. I'd be happy to. I think that's a good like separate
Yeah.
session because there are a lot of things, a lot of different considerations with gender affirming therapy than just dealing with
Mhm.
hormonal changes in the voice from a cyclical point of view, which I think is also interesting
Mhm.
and more impactful, I think, for singers than not. But I know a lot of us are working with singers, so that's why I always throw that in, the singing aspect of it. Um, and then I am going to offer a pelvic floor course probably in April. So you'll learn everything you've ever wanted to know about the pelvic floor and more. Rachel, when you did your doctorate, did you talk about breathing from did you include pelvic floor in the breathing in your?
No, it's funny. It really came into, I mean, it was a little bit
Okay.
talked about, but it really came into the forefront. So my doctorate was finished 12 years ago. It was 2012 that I graduated.
Okay.
And it's in the since then that the journals are really starting to address it. People
Right.
caught on.
Yeah, it is definitely a new inclusion, which is why I'm excited about sharing it with you because it is very cool and interesting, and I get to, yeah. I really would like to read your paper if you'll share it with me.
It's a bit out of date. I have an article in the Journal of Voice that's a little bit more up to date.
Oh, great.
About singing and lung health is my thing. That's why I get the COVID people for voice.
Love it. Would
So
you
I
mind
get all the
sharing?
people with asthma and COPD, but I wrote about use of singing lessons as a adjunctive airway clearance technique for cystic fibrosis.
Wow.
So I live in the respiratory physiotherapy world.
Super cool. Would you mind sharing that with us in the Google Drive?
Sure, sure. If I ever get my act together, if I'm ever not in school again, then I have to update it. I have yeah, the research has really come very far in terms of seeing singing as exercise. So that's, you know, that's cool. There's more coming.
That is really cool. I think that there was another article I remember reading in the Journal of Voice about the physiologic benefits of singing, maybe even psychological and physiologic. I'm trying to think who wrote it. I want to say Jack Jang or something, but if I find it, I'll throw it in the Google Drive too. Um, I didn't know how much discussion we'd have tonight, so I kind of I last time it was so great because it was a really nice balance of like half presentation and half discussion, but I wanted to leave enough room for discussion. So I apologize that I'm a little short. I know.
I do have a
Yes,
question really
yes,
quick.
yes, yes, yes.
Sorry, just about joining tonight. I couldn't find the link and I thought, did I miss it? Was it in an email? Was it on Facebook? And then I just took a guess and went back to the old Zoom link and then typed in COVID. I was like, maybe the password's COVID. And then it finally worked. But I just wondered, is it the same link every time with a different password? Did I miss something? I may have missed something because I was late to
Oh, you're fine. It's I will always do a dorky password like COVID or MTD or whatever the topic is. And when I send out an email early in the week with the link and the password. Um, so uh,
I don't know where it went. Maybe it ended up in
okay,
my spam or something.
I apologize.
No,
Um,
that's okay. I just wanted to make sure. I'm like, where should I be looking? I thought it was email, but just wanted to
but if
clarify.
you don't see something from me, you have my email, right? So just email me and say, hey, I didn't get anything from you this week. Can you please share with me? I don't want you to have to miss it um, ever, but I do try to send something out. But I'm glad you figured it out that COVID was the password. Very good.
I was like, I took a shot, you know.
Kate, you were working with Kitty Bertolini to come up with dates for the resident workshop.
Yes,
Is
yes,
that definitely happening?
yes. So she just said to me, our group in particular, if we have 15 to 20, we'll get the discount that she wrote about in the that I posted in the Facebook group. Um, so I think it's like 395 or 595 for both. And then she said there's always a student discount, but I don't know exact. So she's getting back to me on that. Um, so I know Rachel, you were curious about that, or oops, sorry.
I will do it. I will do it come hell or high water. So
Okay, yeah. Um, it's
I'm
so great.
definitely in too. Yeah.
Okay, so I think what I'll do is while she's getting back to me, I'm just gonna get like who try to get a definitive list because if we have 15 people or more, I'll just send her the list and emails, and then she can contact people and register them because she was trying to figure out how we could register with the discount. And so I think if we just come to her with the list of people and their emails, then that can happen pretty slickly. But yeah, it's I mean, resonance is always an important thing, and you'll always use it in voice therapy. I use it all the time. And even when I'm writing voice therapy programs, there's always a resonant voice component to it.
Mhm.
So, I think it was one of the first things formal trainings I took, like 2000 or something crazy. So, long time ago. Um, And I know I mentioned most of the therapy programs that we've talked about already, but does anyone have any questions about what I recommend or what some of my favorites?
I started working with my little 5-year-old with the inhalation, and it is so much better than the straw phonation.
Oh,
So
good.
she's enjoying playing with her voice. So that's really great.
Excellent. That makes me
Yes.
so happy. Yeah, inhalation phonation is just so effective. And once you can get people to do it well and not like worry about what it sounds like, um, they it has so many good elements of release, of entrainment, of stretch, of improved vocal fold vibration, all just with one little technique. Plus it prepares the breathing mechanism really beautifully too. So
Mhm.
yeah, I use it all the time. I'm glad you do too. Well, if you guys don't have any other questions, I think we'll just sign off for the night. We're gonna meet again 2 weeks from tonight, same time, and I'll send out um, probably a week prior to so you have the links and the passwords, and if you don't get it, you'll have time to send it to me. It could be, Anne, that I just had an old group list because you joined relatively recently that it somehow I just didn't get you on there, but I apologize.
No, that's okay. And I realized I was very last minute because in my brain I'm like, oh, I'll just hop on and get on. And I was like, oh, I should have checked earlier that I had that password, or, so no worries.
Okay, great. Well, thank you all for being here tonight. As always, beautiful discussions and questions, and a pleasure to be mentoring you.
Thanks
Have a
so
good
much,
week.
Kate.
See you
Yes,
next
Thanks,
thank
week.
Kate.
you.
Okay,
Thanks,
bye.
Kate.
Thanks,
Bye
Kate.
bye.
Thank
Thank
you.
you.